Hi, welcome back to General Examination and Vital Signs, and this is video clip 8.2. We'll be talking about height and weight in this particular clip, so let's carry on. In general, we'll be thinking to ourselves, why do we need to calculate BMI? Why don't we just measure serial weights, right? So I think it depends on the context. Serial management or measurements of weight is important, particularly if you're monitoring the acutely ill or chronic disease patients. For example, people who may be suffering from conditions that have got malnutrition syndromes, or sometimes some of us may be experienced in managing heart failure patients for which the monitoring or serial monitoring of weight could tell us signs of early fluid congestion. We would usually ask our patients to record BMI rather than just weight alone, unless the serial weight monitoring is required. And if they come to a clinic every now and then, you would usually measure BMI or rather record BMI. And because in a grown adult, the height should not vary too much at all, whereas in a child, because they'll be growing quite quickly, particularly through the puberty years, and so the BMI calculator becomes something that's important. And essentially, just wanted to point out that the Health Hub has got a BMI calculator that is found in there, like the one in the slide over here. So there are many complications of obesity, and this is a list of the various complications. It's critically important for us, particularly in the society of increasing overweight or obese patients, to be considering BMI, because that could be one of the modifiable lifestyle modifications that we could opportunistically talk to our patients as well about as well. I would like to point out that for Asians, the BMI cutoff is different than in Caucasians. The cutoff for Asians to determine us to be overweight really is at 23 rather than at 25 for the non-Asians, because at any given BMI, the amount of total body fat and ectopic fat is different between Caucasians and Asians. And unfortunately, it also means that Asians are, well, with a lower BMI, considered obese earlier than Caucasians. Okay, so some of you might be asking, why pick on Asians, right? So we need to explore the concept of abdominal obesity and generalized obesity, where the Asians tend to be a little bit more predisposed to abdominal obesity, unfortunately. So there were actually Asian studies that were done, and we're talking about comparing 2017 to 2016, for example. And you can see the number of Asians in India compared to Korea. If you look at how the prevalence of diabetes is in India, which is 8.8%, and even in Korea, 4.8 million or 13.7% prevalence of people above 30 years old have diabetes. A quarter of the population in Korea has got pre-diabetes, and so this is actually a bit troubling, right? The fact that Asians are diabetic so commonly. Now, in the Hong Kong Chinese study, it was found that the risk of having diabetes mellitus or hypertension was at a lower BMI or waist circumference levels in Chinese than in Caucasians. And in Asians and South Asians, there's more severe inflammation, insulin resistance, and liver fat, even when non-obese, by BMI standards that are used for Caucasians. There's also this metabolic state that's linked with excess body fat and ectopic fat that's deposited at various organs. There's also excess regional fat deposition. There are all sorts of abdominal, visceral, subcutaneous, and deep subcutaneous fat that builds up and causes this inflammatory resistance and milieu in Asian Indians. And that could actually be contributing towards this dysglycemia type of a presentation that is observed. And all these articles can be found in the link at the bottom of there if you're more interested. This slide details the various causes of weight loss. It could be from either malabsorption or poor intake of foods. And of course, we'll probably come to mind quite frequently would be cancers and potentially serious and prolonged infections like HIV, untreated HIV infections, or chronic inflammation of the inflammatory bowel diseases. It can also be due to malnutrition, as I mentioned earlier, people with anorexia or alcohol abuse. Those are signs and symptoms that they're not nutritioning themselves very well. With people with an increased appetite, and still can cause weight loss, right? Oh, I'll be very happy to have that as well. But thyrotoxicosis is one of them. Type 1 diabetes is one of them, because it's a situation where there's increased metabolism in spite of the increased intake. And so this complaint of weight loss does not always correlate with true weight loss. Essentially, they might not even be really losing weight in this situation. And there are also situations where there are temporary weight loss, right? Things like anxiety or depression. I don't know about you guys. Maybe now in PharmD you're stressed out and so you get this temporary weight loss. But once you go back to your usual environment that you're used to, you no longer have this weight loss anymore. Okay. So I think it's critically important if you were dealing with geriatrics patients as well, because cachexia is one of the things that we are taught to also watch out for when you're working with geriatrics. And sometimes for geriatrics, the most important thing is really about nutrition so that they can maintain healthy and aging well with respect to their conditions. This has two important tables on vitamins and deficiencies and how there could also be presentations of, say, osteomalacia or anemia, any sort of bleeding disorders, something for you to think about. I suppose in Singapore, the most common is going to be like vitamin B deficiencies type associated with megaloblastic anemia, for example. I think that we are a very blessed country and many of our foods have got fortification with a lot of these additives, whether it be folate or B1, and so it's very rare to see that locally. But I suppose if you were dealing with a migrant population, or if you were carrying out mission trips, or you went overseas to help out with the healthcare out there, you might actually see people presenting with the various syndromes because of vitamins deficiencies. There are also drugs associated with weight gain, which I think is important to think about, particularly for pharmacists when we get a drug history. Of course, a very famous one is insulin. And there's several others like antipsychotics and anticonvulsants and certain antidepressants as well. Of course, the corticosteroids we all know, right? 吃了会胖. Yeah, in Mandarin it means eat already you will grow fat. Yeah. Some of the other agents may be also worthwhile noticing. I put a post-it of a little girl over here just to make fun of the fact that short stature is usually familial. And sometimes significant childhood illness can reduce the rate of growth and limit the final height. And sometimes some people just don't grow to their maximum potential. There could also be associations of diagnosis of disorders like renal tubular acidosis and intestinal malabsorption. So for people who don't seem to grow like the usual growth charts, the young people, it might need to prompt further investigations like hypothyroidism or intestinal malabsorption. And this is something that as doctors or clinicians, you might want to also suspect and send for further diagnosis. So the loss of height in older patients is not, I guess, unfamiliar to people, particularly for females, because it could be secondary to osteoporosis. And we've all heard about how the vertebral fractures could be asymptomatic and causes sometimes a shortening of a person's height. And essentially for women, a loss of more than 5 cm in height would warrant investigation of osteoporosis. And that's why, again, I want to reinforce that each time a person comes back for physical examination, it's important to be tracking all these things and to watch out for any sort of abnormal signs and symptoms or changes in their vitals and parameters. Okay, so I'm sure a lot of people have heard about the Marfan syndrome, whereby there's a picture in picture A over there where they've got extra long limbs, extra fingers, long fingers, very, very tall. Hypogonadism is another one that predisposes to very tall stature, and pituitary gigantism. I'm sure everyone has gone to museums and seen how gigantism has caused very, very tall individuals, some of them over 2 meters in height as well. And so these are quite rare conditions, and I will not waste time talking about this, but might be something that you suspect as well. Nutritional status, I think, requires a little bit of mention. Malnutrition can potentially lead to any sort of delay of recovery from illnesses, from surgeries. Of course, you have heard of certain surgical services making sure that there's some sort of nutritional status assessment for people who are undergoing major surgeries, particularly the older individuals, because you want people to recover quickly. People who are poorly nutritioned sometimes will take a bit longer to recover from major surgery. Malnutrition can also lead to delayed wound healing, right? So it's important to record BMI initially and then repeat weekly in the acute setting. Especially if you're tracking for malnutrition, you can then monitor people in outpatient settings or in the community to monitor a nutritional status. You can also do that every now and then. For the vitamin deficiencies, I guess it's something that you want to look out for in the elderly and alcoholics. And for B12 as well as B9, which is folate deficiencies, you would see macrocytic anemia, which I mentioned earlier. and glossitis, which is seen in this picture over here. Glossitis refers to pain, smooth red tongue, and a burning sensation around the lips. That's really what glossitis really means. And B12 deficiency is often seen in people with pernicious anemia. I actually remember having a patient who had pernicious anemia before, and he had intrinsic factor negative, so he was not producing the IFs at all. And I recall that he refused to have IM injections, and this is at the start of the circuit breaker in 2020. He refused to come back to hospital to get his IM injections, and so he insisted on taking cyanocobalamin. And for some strange reason, he did respond to that, so I could never figure out why his B12 deficiencies actually did improve, even though he was lacking in intrinsic factors. But good for him that he did. And some of these other conditions like small bowel overgrowth or ileal disease or resection can present as B12 deficiencies. Vitamin C deficiency is probably a lot less common in Singapore, and this is a situation where you produce a lot of extensive bruising, particularly in adults or elderly who live alone. I'm sure you've seen people with those excessive bruising, right? And sometimes it's because they have no access to fresh fruits and vegetables, and therefore their vitamin C intake is impacted. The other one is vitamin deficiency, which you often see in alcohol dependency. Also, the scurvies, this picture of scurvy over there is related to vitamin C deficiency. And so for people with fat-soluble vitamin deficiency, like small bowel malabsorption or liver and biliary tract disease, people with gastric bypass surgery, like bariatric surgery, it might be important to consider fat-soluble vitamin deficiency. And that's why sometimes you see people prescribe fat-soluble vitamins for them. Okay, finally, the last concept is on fluid status, and I think this is critically important when you're doing critical care for your rotations in the coming year. So just to state that the adult and male and female have got different amount of body water. The adult comprises of 60% body water, whereas the female is 50% body water. Unfortunately, it's because we have more fat. So the infant has a lot more fluids with respect to the rest of the tissues in the body, and that's why they're also a little bit more predisposed to dehydration complications. And so the fluid compartments and fluid homeostasis is critically important, and I think this is something that in Prof. Howe's lectures also you will also be looking at fluid homeostasis. And this would also be an important factor upon which you will build fluid replacement in a critical care patient. Okay, so watch out. Why is hydration status so important? Well, dehydration is sometimes quite hard to tell, and sometimes dehydration can be associated with unusual rises in serum creatinine, right? So it's important to assess hydration, particularly when those patients that present to you have got excessive fluid loss or complaints of, say, vomiting, diarrhea, sweating, or burns, or when ambient temperature is raised. And it would be useful to weigh the patient if you had baseline body weight for the patient as well, because remember, the fluids change in your body would usually be the one that results in the most measurable change in your body weight just overnight. Same thing as to why we tell our patients to track their body weights if they've got heart failure, because the accumulation of fluid would then usually be the most telling and most early signs of fluid congestion. Okay, what are the other classical signs of dehydration? The loss of skin turgor, where you pinch and then it just drops off instead of suppling the supple skin. And this usually occurs when there's severe fluid loss of 4 to 6 liters. Think about the people with heat stroke, for example. And they can also present with very low blood pressure, rapid pulse rates, because the body tries to compensate, right? And postural hypotension, because the body is now unable to compensate, and the diastolic pressure and all that don't seem to rise when you change from a seated position to a standing position. Now, a dry tongue can be an unreliable indicator because even in dehydration, they can look moist. And sometimes also looking dry doesn't always mean that they are dehydrated. Okay, so dehydration is quite hard to assess, and it probably be done in conjunction with a history taking. So these are some classical signs of dehydration, and this is a table that you can have a look over here. Now for edema, basically edema usually refers to tissue swelling due to increase in interstitial fluid. So in the previous slide, we've talked about intravascular spaces. Now we're talking about interstitial spaces where there's accumulation of fluid, and that's how you get edema. So it's not really about too much fluid in the vascular spaces, but more in the interstitial spaces. Okay, so it can be generalized. It can also be localized. For example, ankle edema due to, say, heart failure or fluid retention. Or it could also be postural for people who have been lying overtly long, say maybe a stroke victim who has been lying for some time, and sometimes you do see some sort of edema on the limbs, right? The cardinal sign of subcutaneous edema is usually pitting edema. And what does pitting edema mean? I'm sure you can Google for what pictures look like. But pitting edema is when you press in the flesh and it stays indented for some time. And the plus signs they usually see people say, right, plus, 1 plus or 2 plus or 3 plus. The number of pluses actually refers to the number of half minute counts. So the longer it takes to come back to the usual state, right, is the number of pluses that you would have put on. And essentially, the pitting edema may not be so obvious until the body weight put on is like an additional 10 to 15%. So you need to also differentiate pitting edema with fluid retention versus also dependent edema, which also can present as pitting edema. Now, how you usually tell between the two is that if it's really due to fluid retention, right, it should not go away that much with lying down. Whereas for dependent edema, you will hear the patient complain that when they first get up in the morning, it's not there, but gradually as the day goes by, the ankles start to swell because it's gravitational. And so for those people, you don't really have to worry about fluid retention, but it's more like a dependent edema kind of situation. And sometimes at the end of the day, all they need to do is put their limbs up and they'll be fine. So that's why it's important to do all these things not in isolation, right, but more in a total picture of all the signs and symptoms or the complaints that the patient has. And that's how we have made a decision on the overall physical examination. Okay, so these are all little signs. So you're almost like a medical PI, right, or like private investigator, trying to put all these signs together to come to a very worthy diagnosis. Okay, so day-to-day alterations in body weight usually is the most reliable indicator of fluid overload. And so it's critically important, particularly if you have a patient who has habitual drinking habits, like CKD patient or heart failure patient, to get them to monitor the blood pressure, the body weight every day. Some other conditions like mixed edema or chronic lymphedema do not pit on pressure. And so these are usually accompanied by those signs and symptoms of, say, hyperthyroidism or hypothyroidism, and therefore is a mixed picture thing, and again, not taken in isolation. Right, ladies and gentlemen, that takes us to the end of this segment with height and weight, and we'll go on to clip 8.3 for vital signs next. See you soon.